Very good afternoon, and we have this course on refractive surgery, OOPS moments, and handling complications of all kinds of situations. And we have a stellar faculty today. My name is Gaurav Luthra, and I'll be one of the speakers as well. We have with us Dr. Sonu Goyal from Jaipur, who's doing all kinds of refractive surgeries and presents internationally in almost all forums, conducts courses. We have Dr. Chitra Ramamurthy, who is again a very passionate refractive surgeon, does a tremendous amount of surgery of all laser corrections and ICLs and everything. We have with us Dr. D. Ramamurthy again, who's a master at not only refractive surgery but refractive cataract surgery and premium IOLs. He'll be talking to us about certain unhappy patients and how to manage them. We have with us Dr. Ajay Sharma from Gurgaon, who's the head of the IQ group of hospitals, again, who's prolific refractive surgeon. We have Dr. Kumar. I think he'll be here any moment now. He is from Bombay. He is again he's with over 25 years of experience in refractive surgery, does almost all kinds of surgeries and deals with complications. And we have Dr. Sri Ganesh, who is, we all know what Dr. Sri Ganesh does. He's a brilliant refractive surgeon, pioneer in most surgeries. So I think I'll first invite, should I go with my talk first? Okay, then second you can go. Okay. So since I am on the podium, I'll invite our speakers and panelists to please be on stage. So Dr. Ramamurthy, Dr. Ajay, Dr. Kumar and Sonu, if you would like to come here, and you want to stay there? Okay, after this. So I wanted to share a few oops moments that I've had now. I would like to give credit to my friend Kumar for discovering this term of the oops moments. He conducts a course on oops moments in cataract surgery in ASCRS, and I thought this is only appropriate to bring it along to refractive surgery as well. And I think Dr. Namrata has been conducting oops courses in the AIOS, and they bring out quite a good number of nice ideas. So this is something which, in SMILE, I'm talking about lenticule complications and how to manage them and how to prevent and preempt them. One of my fellows was operating here just about a couple of weeks back, and so fairly good so far. Everything looks nice. We typically want to identify the deeper plane first, and then on the other side we try to identify the cap plane. So far so good. And so they realize that the two planes meet. If the two planes meet, that means we haven't really identified the lenticule plane well. So my fellow is trying to identify under my guidance and trying to see whether we can identify that deeper plane. And eventually he thinks he's found it, and now wants to kind of extend that plane a little bit to one side or the other, and is finding it very, very tough. It's very, very tough. He's not being able to make space. Not, it's the manipulator is not moving from one side to the other. I immediately stopped him there, and now I have taken over and I have identified the plane. So just let's go back for a moment. I could immediately see what was happening. I'll just take you back there. So he's found a plane, which is the lenticule plane, and he's trying to move it to one side or the other, trying to identify that plane. And you can see that he's not being able to move. So what's basically happened is, if you're too enthusiastic, you can actually very easily enter into the stroma and create a false passage. And then obviously the telltale sign is that it will not move much from either side. If you force it, it will move somewhat, but you'll create a tear, you'll create a false passage which extends. So at this point, you have to become very sure that you are not in the wrong plane. So once I took over, I was able to now, here I've gone from another area and identified the plane, and then of course it moves to the side very easily. So this obviously makes it easy. Now I was able to complete the surgery, everything went well, and then at the end of surgery, after removing the lenticule, just to demonstrate, I was able to show that once the surgery is over, the lenticule is out. Now I'll just go and show you which plane had been created. So this is the plane which was created and where my fellow had managed to create a false plane. So this one has to watch out. Let's go to another situation. Sometimes if you have difficulty in dissection, and especially if your lenticule is too thin, and sometimes we tend to decrease the lenticule's minimum thickness to 10 microns, especially, or if you're dealing with a very thin lenticule to begin with, and if you manage to get some dark spots, or you get some situation where the dissection is not straightforward, and if you're not careful, you may cause a lenticule tear. So of course, if you manage it carefully and use the right amount of forces, you will not do that. But here I'm now dissecting the lenticule plane, and suddenly I realized that something funny is going on. I can see a tear happen here. Let me take you back again. There's nothing much that I did except that this lenticule was a thin one. It was about 50 microns. And so as I'm coming to this side, there is some resistance, and as I do that, I find that if you notice here, there is a lenticule tear which is created. So one has to be very observant. It happens very, very rarely, but it can happen. And this can happen if your dissector is sharp. So it's a good idea not to use a very sharp dissector. I have a very blunt one, but still it happened because the lenticule was very thin and maybe there was strong adhesions in this area, and I was trying to force it to this side. So the trick is to break through at 6 o'clock and dissect on either side, and then make sure that you don't have a retained lenticule at 6 o'clock. But here I ended up having a lenticule at 6 o'clock. So I don't have much choice now. I'll have to bring out first the other part and do what you want. You will not be able to find that plane very easily. There's a very clear lenticule tear over there. I'm going to bring out first the bigger part of the lenticule which is free. I'm trying to go get under that lenticule, but it's of no use. I'm staying in the cap plane most often because that lenticule is stuck. So I'll have to probably go in and identify. So here I bring out this part of the lenticule. These are only 1 or 2 of the lenticule tears, so I had to really look for this video because maybe in a 5,000-10,000 eyes, there are only 2 situations where this actually happened. But when it happens, you should know how to deal with it. And if you can't identify it, sometimes it helps to put in triamcinolone into the interface to stain this area. Otherwise, you can see it on the slit lamp or on the OCT. Intraoperative OCT can help you. So the trick is now to find a space where the lenticule has been dissected a little bit. So I was able to find one small area where there was a free area where I could get under the lenticule and over. So the forceps has to be able to catch the lenticule at some place. Otherwise, you'll have to do a circle software and go in. So I was able to identify one area where I could get a hold on it. Now, once you get a hold on it, it's almost like a capsular excess or a lenticular excess, and then you can just move it to one side. So here I'm, again trying to get a grip on it, and then it can be a little messy, but once you get a grip on it, you'll be able to tear it. There. Now I've brought it out. So essentially, you should be able to find a way to grip it, and you have to be very patient. It doesn't happen very easily, but once you find that correct plane and the correct area to hold it, you can do it, and then you can spread it out and see whether you got the whole lenticule out. At the end of surgery, you should check on the slit lamp on the machine and also outside the machine, and maybe do an OCT just to see that nothing else was left behind. And here you can see that we've been able to complete that lenticule by placing it on the cornea and manage it. Another situation, sometimes this is again extremely rare. So these are complications which we saw over the last 6 months, and I was able to put them first here for you because these are new things. A buttonhole is extremely rare, but if you are doing a thin cap and sometimes in area of pannus, especially in the peripheral area where you do this, just see how effortlessly a buttonhole can form. Now I'm doing the deep plane first, and now I'm going to go identify the cap plane. And I'm just going to move this to one side, and there comes. So I managed to penetrate the cap. Now I was wondering why this would happen. My cap was about 120 microns thick. It doesn't usually happen. We do this all the time. But then I realized, and I looked very carefully, this area had a cornea, had some pannus, and this area had a very fine corneal opacity, which had probably caused some thinning in that area. So there was probably epithelium which was filling in. So the amount of stroma was probably very less. And this was unhealthy because this happened in the second eye as well in the same area. But I was more careful, so I could prevent it. But then you have to be careful. So what I'll do now is I'll come back because this can potentially be a space for epithelial ingrowth to happen. I'm going to go from the other side and create the cap plane. So I just went to the other side. So both my planes are identified. I'm going to leave this area alone. I won't come into that area at all except till the end. And then now I'll just go very carefully from the other side. So these are oops moments which help you learn. And I think learning never stops. I've been doing Smile for 10 years, but this thing came up just about a few months back, and one keeps learning new things that can happen when you operate, and then you can share this. And I learn so much from all my other colleagues who bring in their situations, and that's what this course is all about. So very carefully making sure that I don't have anything left towards the end. And in this area, I have to be very, very careful because that buttonhole can extend at any time. The cornea is not healthy at all there. So I'm very gently making sure that the cap is dissected, and then of course the lenticule as well. It's probably much easier to do the lenticule in these cases because it's a much deeper plane, and then I can get this lenticule out. So going on, sometimes you'll have a situation where patient becomes a little uncooperative, starts squeezing, especially if the conjunctiva is wet. and you can start seeing these telltale signs of a potential suction loss happening. This fluid can start creeping in, and these are telltale signs that something is going to go wrong, and you really want to complete the lenticule cut in such situations before you have a suction loss. And you can see I was able to do the side cut, and then probably I was watching when to lift off my pedal, and till the time that you are not into this, you can still go on. Once I cross that area, I'm a little safer. You don't always get away, and best to at this point probably let go and go and come and do the cap cut again. So now the tough part is I'm not sure whether the side cut happened, so I'm just identifying. I could find a very small area of 1 millimeter where the side cut was there. And from here I'm going to go in, and then it's going to be a little tough because instead of the 3 millimeter that I was hoping for, I probably got only a very small area. Of course, the two planes are well dissected, but that area from where I can enter is probably not so well defined. So I will then eventually find a place, and then once I find a small area where I could go in, I can complete the surgery more easily, and this happens nicely, and then I can complete it. So typically in such a situation, it's best to abort the procedure once your lenticule side cut is over, and you can then go back and do the cap cut again. Here I wanted to just pause, and I'm going to stop my presentation and invite Dr. Ramamurthy, but I'll ask the other panelists who are sitting here, what would you do? Because on the Smile platform, we can do this. You have a cap cut and you can repeat a cap cut. What happens to Silk and Clear and other platforms, which do they also have? Silk, I know, has a biconvex lenticule, and probably if you abort during this stage, you can't go back and do it, if I'm not wrong. But those who are experienced in Silk, and I know that you all have machines of that kind, and also you have Clear, and Dr. Ajay also does Silk, I think. Can you go back? What happens to you when you have a suction loss kind of a situation like this? Maybe you can now come here. Ma'am, Dr. Chitra, you can also come here. You have to go? But you have to talk, because?
No.
Okay, then come and sit here and at least take part in the discussion. Dr. Ajay, please come. Kumar, come.
In Silk and Clear, we don't have that ability to, have something like the Circle software to complete it. But since we have all of them, what we have done is brought them on to the Visumax and done it. And we
So
are
then
also
you can,
wary of the
you'll
fact.
be able to create a flap, right?
Yeah, we have to create a
So
flap.
what I wanted to know was, suppose you had started the second cut and
Okay.
it's a biconvex. So what is because that now it's not going to be planar. So how much, do you know how much is the cap in the center and how much is it in the periphery? For example, Silk, suppose you're doing a Silk and your, the second pass was almost halfway through, and then you have a suction loss. So because it's going to be a variable thickness, right? And if you have, like in the central area, say 100, 120 microns, in the periphery it's going to start becoming thicker, and then you need to be at least 30 microns off that plane. How are you going to do that?
I think that lenticule, the convex configuration is slightly exaggerated. Though it's figuratively shown like that, the variation is not that much.
Okay.
Maybe a difference of few microns. To be frank, I'm not aware of the exact dimensions.
Okay. So do you put in a cap thickness in Silk?
Yeah.
And is that because it's not uniform, right? Cap thickness will be different in the center. So when you feed it, it's basically what you have in the center, where it is the thinnest. In the periphery, it will become thick anyway. So that's what you are going to assume.
Yes.
Kumar, in Clear, what do you do? Okay. Huh. Okay. Why don't you come here and speak on the mic? So you can create a flap in with the same interface. You don't have to change it. And okay. And then is your lenticule biconvex, or is it like plano-convex like in Visumax? It's plano-convex. So it's the upper surface is plano and the lower surface is like, okay, perfect. Then it's easy to do, basically.
The big advantage is the OCT.
Right, right.
Very, very big advantage.
But is that OCT so sharp that it can get
Yeah, it will go to the exact same plane.
I see. Wonderful. Great. So I think with that, we'll move on. If there are questions, please make a note of them and we can answer them towards the end of the call.